Welcome to this tutorial on neurovascular magnetic resonance angiography. I'm AI Chevelle. This session is based on material published in Radiographics in November 2021 and is brought to you by Dr. Yu-Dong Chen. Our focus will be on understanding the evolving role of magnetic resonance angiography in the assessment of neurovascular disease. To begin, let's familiarize ourselves with the common abbreviations that will be used throughout this lecture. qMRA stands for Quantitative Magnetic Resonance Angiography. SAR refers to specific absorption rate, a measure of radiofrequency energy deposition. SNR is the signal-to-noise ratio, while CNR is the contrast-to-noise ratio. SPACE describes a three-dimensional T2-weighted sequence, optimized by variable flip angle evolution. Common vascular terms include TOF for time of flight, TRICS for time-resolved imaging of contrast kinetics, and MOTSA for multiple overlapping thin slab acquisition. In pathology, we will reference AVMs, or arteriovenous malformations, AVFs, or arteriovenous fistulas, and DAVFs, which are dural arteriovenous fistulas. Clinical contexts such as TIA for transient ischemic attack, ICA for internal carotid artery, and MCA for middle cerebral artery will recur frequently. These abbreviations will serve as the essential language for discussing magnetic resonance angiography protocols and findings. Think of neurovascular magnetic resonance angiography as a puzzle made up of interconnected components. We will explore 5 domains. 1. Extracranial magnetic resonance angiography. 2. Intracranial magnetic resonance angiography. 3. Spinal magnetic resonance angiography. 4. Advanced imaging techniques. 5. And importantly, the rationale why magnetic resonance angiography is chosen in specific clinical situations. Each piece contributes to building a comprehensive picture of neurovascular assessment. By the end of this presentation, you should be able to 1. Recognize both the strengths and the limitations of magnetic resonance angiography for neurovascular evaluation. 2. Understand the principal imaging techniques, along with adjunct sequences that are essential for head, neck, and spine vascular imaging. 3. Identify the most common artifacts that may affect neurovascular magnetic resonance angiography interpretation. 4. Discuss the role of intracranial vessel wall imaging in evaluating vascular pathology. 5. And finally, review common neurovascular conditions encountered in clinical practice. Let's now establish a broad overview. Magnetic resonance angiography can be categorized into static and dynamic approaches. Static techniques include time-of-flight MRA, performed without contrast, contrast-enhanced MRA, which uses gadolinium, and phase contrast MRA, also typically non-contrast. Dynamic techniques are represented by time-resolved MRA, which enables assessment of vascular flow over time. Adjunct and advanced methods include the MPRAGE sequence for plaque characterization, dedicated vessel wall MRI, and quantitative MRA utilizing phase contrast velocity mapping. As illustrated in the axial post-contrast TOF image, the addition of contrast may reveal vascular lesions, such as this aneurysm at the carotid terminus. Later in the lecture, we will discuss in detail the clinical scenarios where contrast administration provides a significant diagnostic advantage. When comparing CT angiography with magnetic resonance angiography, it is essential to weigh their respective advantages and limitations. CT angiography offers rapid image acquisition, very high spatial resolution, and the ability to readily evaluate vascular calcifications. However, it exposes patients to ionizing radiation, carries risks of allergic-type contrast reactions, and may cause contrast-induced nephrotoxicity. Dense calcification can also obscure the vessel lumen. Magnetic resonance angiography, by contrast, avoids ionizing radiation while providing high spatial and contrast resolution. It can achieve superior temporal resolution with dynamic sequences, allows for carotid plaque characterization, and, importantly, time-of-flight MRA can be performed without any contrast at all. Limitations include poor visualization of calcification, contraindications in patients with certain metallic implants, and, in the case of contrast-enhanced magnetic resonance angiography, perceived risks such as nephrogenic systemic fibrosis and gadolinium deposition. Thus, the choice between CTA and MRA depends on clinical context, patient safety considerations, and the diagnostic question at hand. The primary clinical indications for neck magnetic resonance angiography include evaluation of patients with a carotid bruit or significant risk factors for carotid atherosclerosis, screening for transient ischemic attack, assessment of focal neurologic deficits, particularly when stroke or arterial dissection is suspected. Preoperative evaluation of high-flow vascular malformations, as demonstrated in this case example. A patient undergoing TIA screening MRA shows high signal within a carotid plaque on MPRAGE with less than 70% stenosis. Contrast-enhanced MRA confirms the stenosis on 3D reformations. These findings highlight why adding MPRAGE to carotid imaging can be crucial in identifying vulnerable plaques. Historically, 2D time-of-flight MRA was the initial study of choice for carotid imaging. It covers a large region from the aortic arch to the circle of Willis and is sensitive to hemodynamically significant stenosis. However, its specificity is poor, particularly at the carotid bulbs, because it is highly prone to artifacts. With the advent of 3D MOTSA time-of-flight MRA, accuracy improved significantly. Although coverage is more limited, this technique provides high sensitivity and specificity for detecting stenosis greater than 70% in the internal carotid artery. Finally, first-pass contrast-enhanced MRA combines the broad coverage of 2D TOF with the high resolution of 3D MOTSA. It requires intravenous gadolinium, but today it is often regarded as the standard approach for comprehensive carotid evaluation. A practical protocol for neck MR angiography includes the following steps. First, acquire 3-plane localizer images. Next, obtain time-of-flight MRA, typically using axial 2D TOF for the entire neck, with an optional 3D TOF targeted at the carotid bifurcations. Incorporate MPRAGE sequences in either the axial or coronal plane for assessment of vulnerable plaques. Perform contrast-enhanced MRA, generally acquired in the coronal plane. Finally, create 3-dimensional rotational reformations to provide multiplanar views. In terms of timing, TOF sequences require 5 to 7 minutes, MPRAGE about 5 minutes, contrast-enhanced MRA just 2 to 5 minutes, and the post-processing of 3D reconstructions is typically performed by the technologist after the scan. The time-of-flight technique relies on gradient echo, T1 weighted imaging, and is usually performed without any contrast administration. This makes it the sequence of choice for routine head MRA studies and for patients who cannot receive gadolinium. The principle is straightforward. Flowing blood continually brings fresh unsaturated protons into the imaging slice, producing a strong TOF signal. This is often referred to as flow-related enhancement. To reduce unwanted venous signal, a saturation pulse is applied above each section, suppressing blood that flows in the craniocaudal direction. In this way, TOF MRA selectively highlights arterial flow while diminishing venous contamination. In 2-dimensional time-of-flight imaging, coverage typically extends from the aortic arch to the level of the sella, with a section thickness of about 2 millimeters. This technique offers several strengths. It is fast, making it suitable as an initial screening tool. It provides a good overview of tandem stenoses. It serves as a useful localizer for subsequent 3D contrast-enhanced MRA. It is highly sensitive to slow flow and is particularly valuable in confirming vascular steal phenomena, such as subclavian steal. However, there are important pitfalls. Visualization of vessels running parallel to the imaging plane can be poor due to in-plane saturation. The method is also prone to stair-step artifacts and turbulent flow artifacts, especially when sections are too thick or patient motion occurs between slices. 2-dimensional TOF is extremely useful in diagnosing subclavian steal syndrome. For example, in this case, contrast-enhanced MRA demonstrates normal flow in the right vertebral artery, along with a focal stenosis of the right proximal subclavian artery. However, the TOF sequence shows absence of flow in that same vertebral artery. This discrepancy occurs because the venous suppression band of TOF has saturated out the retrograde arterial signal. Thus, when TOF shows absent vertebral artery flow, but contrast-enhanced MRA demonstrates flow, the diagnosis of subclavian steal can be confidently made. 3-dimensional TOF imaging is typically limited to the carotid bifurcations, using multiple slabs to capture different levels within the same patient. The main strengths of 3D TOF include higher spatial resolution and signal-to-noise ratio compared with 2D TOF, improved visualization of vessels that run parallel to the imaging plane. The isotropic acquisition enables multiplanar reformations for more detailed evaluation. The trade-offs are longer imaging times, smaller fields of view, and persistent susceptibility to artifacts caused by turbulent flow or in-plane saturation. In contrast, enhanced MRA, a 30-centimeter craniocaudal coverage is acquired in the coronal plane. Most often, fluoroscopic triggering or bolus timing is used to synchronize imaging with the contrast bolus arrival. At 1.5 Tesla, contrast is injected at a rate of 2 milliliters per second. At 3 Tesla, a lower rate of 1 milliliter per second is preferred, as it reduces ringing artifacts. The strengths of this approach are clear. It delivers superior spatial resolution, has become the standard for neck MRA, and avoids the flow artifacts inherent to TOF imaging. Its pitfalls, however, include dependency on accurate bolus timing and the technologist's experience. Mistimed contrast delivery can result in non-diagnostic images. While uncommon, there are also rare risks associated with magnetic resonance contrast administration. A major advantage of contrast-enhanced MRA is its ability to reduce artifacts that are common in TOF sequences. For instance, in this example, TOF MRA suggests narrowing of the proximal internal carotid artery due to an in-plane saturation artifact. In contrast, the contrast-enhanced MRA clearly delineates the vessel, demonstrating that there is no true stenosis. This case illustrates how cMRA improves visualization of vessels that course parallel to the imaging plane, where TOF is more prone to misleading signal loss. In contrast, enhanced MRA, timing of the contrast bolus is critical. If the bolus arrives too early, a ringing artifact may appear where the central aspect of the vessel lumen lacks signal. If the bolus arrives too late, venous contamination occurs, obscuring arterial visualization with overlapping venous structures. Because bolus arrival can vary between patients, pre-contrast TOF imaging remains an important component of routine neck MRA protocols. It provides a reliable backup in case contrast timing is suboptimal. When assessing carotid stenosis, remember that the narrowed lumen is often irregular, not perfectly oval. The recommended approach is to measure the short axis diameter of the stenosis, ideally near the most severe narrowing, and then compare it to the diameter of the normal, non-tapering distal internal carotid artery. This ratio is used to calculate the degree of stenosis according to the NASIT criteria. Multiplanar reformatting is therefore essential for accurate and reproducible measurements. In carotid imaging, intraplaque hemorrhage is one of the most important markers of plaque vulnerability, and therefore stroke risk. MPRAGE, a T1-weighted sequence, provides intrinsic contrast that highlights intraplaque hemorrhage as areas of high signal intensity. Among available sequences, MPRAGE has proven the most effective for detecting intraplaque hemorrhage, followed by T1 fast spin echo and 3D TOF. This makes MPRAGE a critical addition to neck MRA protocols whenever carotid plaque characterization is clinically relevant. Here we see a patient with a recent left middle cerebral artery stroke and less than 50% carotid stenosis by NASIT criteria. Despite the mild degree of narrowing, the axial MPRAGE sequence clearly shows intraplaque hemorrhage and ulceration within the left carotid plaque. Both of these findings are markers of plaque vulnerability. That stroke risk is not determined by the degree of stenosis alone, but also by the biological composition of the plaque itself. Why does identifying intraplaque hemorrhage matter? Because vulnerable plaques correlate more strongly with stroke risk than stenosis severity alone. In patients with recent stroke and confirmed carotid intraplaque hemorrhage, aggressive management is warranted. Options include carotid endarterectomy, carotid artery stenting, and intensive lipid-lowering therapy. For this reason, all neck MRA protocols performed for stroke evaluation should incorporate a MPRAGE sequence. It adds essential prognostic and therapeutic information that stenosis measurement alone cannot provide. When evaluating cervical arterial dissections, it is important to remember a key distinction. Unlike aortic dissections, we do not commonly see a visible intimal flap. Instead, the imaging findings are more subtle and include vascular narrowing, pseudoaneurysm formation, intramural hematoma, and vessel occlusion. MRA and MRI are invaluable in both the diagnosis and follow-up of cervical dissections, particularly for detecting intramural hematoma. For example, in a patient with minor trauma and new transient ischemic symptoms, MPRAGE demonstrates high signal intensity in the distal cervical ICA, consistent with an intramural hematoma. Location is critical here. High signal at the carotid bifurcation would suggest vulnerable plaque instead. Fat-suppressed T1 sequences can also highlight intramural hematomas in both carotid and vertebral artery dissections. Modern neurovascular coils have evolved substantially. They now incorporate a higher number of coil elements, distributed not only from right to left, but also from anterior to posterior. This configuration allows for parallel imaging in multiple directions. The result is a significant improvement in signal-to-noise ratio, while also permitting more aggressive acceleration techniques. In practice, This shortens scan time considerably, with only minimal reduction in image quality. Such advances in coil technology are crucial for making high-resolution neurovascular MRA practical in routine clinical use. When administering intravenous contrast for neck MRA, the injection site matters. Contrast should be delivered from the right arm whenever possible. Injection from the left arm can result in significant venous reflux into the left brachiocephalic vein, which overlaps arterial structures and complicates interpretation. This reflux can be further exacerbated by underlying cardiac disease. The end result may be arterial images that are difficult or even impossible to interpret. Therefore, careful attention to contrast injection technique is an important technical step in ensuring diagnostic quality. To summarize neck MRA, time-of-flight imaging is highly susceptible to artifacts, and contrast-enhanced MRA should be used whenever feasible. TOF remains useful in specific scenarios such as evaluating subclavian steel or in patients who cannot receive gadolinium. For contrast-enhanced studies, accurate bolus timing is critical. At 3 Tesla, an injection rate of 1 milliliter per second with fluoroscopic gating is preferred, and left arm injections should be avoided. Finally, MPRAGE sequences are indispensable for detecting vulnerable carotid plaques and dissections and should be part of every neck MRA protocol. Moving now to head MRA. For acute symptoms, indications include focal neurologic deficits where stroke or dissection is suspected, proven or suspected subarachnoid hemorrhage. In emergency settings, CTA may be favored if imaging is needed within minutes, whereas MRA is appropriate when a slightly longer time frame is acceptable or when CT contrast is contraindicated. For follow-up or subacute presentations, MRA is commonly used for surveillance of treated or untreated aneurysms, evaluation of high-flow vascular malformations, often prior to surgery, and assessment of central nervous system vasculitis. For screening, MRA is indicated in high-risk individuals, for example, those with polycystic kidney disease or with 2 first-degree relatives who suffered subarachnoid hemorrhage. It is also used in asymptomatic patients with significant risk factors for cerebrovascular disease. Clinical examples include a patient with acute TIA symptoms and MCA narrowing on TOF, or another with polycystic kidney disease, and an incidental MCA aneurysm detected on screening MRA. A standard protocol for head magnetic resonance angiography includes the following steps. Begin with localizer images in 3 orthogonal planes. Acquire 3-dimensional time-of-flight MRA as the core sequence. Generate 3-dimensional rotational reformations, which allow enhanced visualization of vascular anatomy. Optionally, include contrast-enhanced sequences, such as TOF post-contrast or fluoroscopically triggered qMRA. The TOF acquisition typically takes about 5 minutes, post-processing requires an additional 3 to 5 minutes, and contrast-enhanced imaging adds about 30 seconds of scanner time. The workhorse of head magnetic resonance angiography is the 3-dimensional time-of-flight sequence. Acquisition details include 3 to 5 overlapping slabs, extending from below the skull base through the circle of Willis. Section thickness is typically 1 millimeter, with slabs about 40 millimeters each overlapping by roughly 10%. Parallel imaging or compressed sensing can be employed to shorten acquisition time and increase spatial resolution. Strengths of 3D TOF. No contrast agent is required. It produces fewer artifacts than TOF imaging in the neck. With its smaller field of view, it is less susceptible to patient motion. It is an excellent screening tool for conditions such as dural arteriovenous fistulas. Limitations include relative insensitivity to slow arterial flow and signal loss in areas of turbulence. Despite these limitations, 3D TOF remains the diagnostic sequence of choice for most intracranial MRA studies, consistently providing excellent vessel visualization. One of the most common pitfalls of TOF imaging is misinterpreting slow flow as occlusion. For example, absence of signal intensity within the intracranial internal carotid artery on TOF may suggest occlusion. However, when compared with contrast-enhanced MRA of the neck, residual flow may actually be present. This pattern is especially seen in patients with proximal carotid stenosis or reduced cardiac output, such as those in heart failure. The key message is that lack of signal on TOF does not always equal vessel occlusion. Correlation with qMRA is essential. Turbulent flow and in plane saturation can also create artifacts on TOF imaging. Consider a patient in whom a focal defect in the paracellular ICA mimics a thrombus. Because the ICA has a tortuous and horizontal course, it is particularly prone to these artifacts. The distinction is crucial. What may appear to be a true thrombus could simply be artifact. If the clinical suspicion is high, for instance, in the setting of acute anterior circulation symptoms, follow-up with qMRA or CTA is recommended to avoid misdiagnosis. TOF-MRA offers an important advantage when evaluating dural arteriovenous fistulas, venous suppression. In a patient with pulsatile tinnitus, CTA may show asymmetric enhancement of the left transverse sinus, but the findings are obscured by venous contamination. By contrast, TOF-MRA suppresses normal venous flow, allowing arterialized venous channels to stand out. This makes it an excellent screening modality for dural AV fistulas, particularly those presenting with pulsatile tinnitus. However, it must be emphasized that digital subtraction angiography remains the reference standard for definitive diagnosis. Three-dimensional rotational reformations are a critical component of every head MRA protocol. They allow radiologists to better delineate vascular anatomy in patients with known aneurysms and improve sensitivity in detecting small aneurysms that may be overlooked on standard axial slices. By providing flexible, multiplanar perspectives, 3D reformations significantly enhance diagnostic accuracy. Contrast-enhanced techniques can complement or substitute for standard TOF imaging. One option is post-contrast 3D TOF, using identical parameters to the non-contrast sequence. Another is first-pass qMRA, which employs fluoroscopic bolus triggering, typically with an injection rate of 1 milliliter per second. Strengths of contrast-enhanced techniques include greater sensitivity in areas of slow or turbulent arterial flow, and particular value in imaging-treated aneurysms. Pitfalls include venous contamination, which may obscure or mimic small aneurysms, and the possibility of enhancing thrombus being misinterpreted as residual flow within an aneurysm sac. In this example, contrast-enhanced MRA shows venous opacification, mimicking an attenuated MCA branch. However, comparison with non-contrast TOF confirmed that this was a normal intracranial vein. Following surgical aneurysm clipping, MRA is limited by susceptibility artifacts created by the metallic clips. These artifacts can obscure the adjacent vasculature and compromise diagnostic value. For this reason, CTA is generally superior and is recommended as the first-line imaging modality after aneurysm clipping. In contrast to clipping, MRA is often superior to CTA in patients with aneurysm coiling. CTA can be affected by streak artifacts from the metallic coil mass. By comparison, MRA provides clearer visualization of the residual aneurysm neck, particularly when contrast-enhanced sequences are included. While TOF-MRA without contrast may miss residual slow flow within the aneurysm sac, qMRA or post-contrast TOF improves detection. In this example, qMRA highlights a residual aneurysm neck, clearly visible on 3D reformations. Flow-diverting stents represent a transformative advance in aneurysm therapy. These are low-porosity endoluminal sleeves that redirect blood flow, allowing branch vessels to remain perfused while promoting thrombosis within the aneurysm sac. They are especially useful for wide-necked or complex aneurysms. The most widely used device is the pipeline embolization device, which is MRI conditional. It can safely be scanned at up to 3 Tesla, with spatial gradient fields up to 0.072 Tesla per centimeter, and a whole-body SAR limit of 4 watts per kilogram for 15 minutes. Understanding these safety parameters is essential when imaging patients with implanted devices. Here we see a patient with a medially directed internal carotid artery superior hypophyseal aneurysm, treated with a flow-diverting stent. At 6 months follow-up, standard TOF-MRA shows no flow within the aneurysm, suggesting successful exclusion. However, post-contrast TOF imaging reveals high signal intensity within the sac. The critical question is whether this represents persistent aneurysm flow or simply organized thrombus. Differentiating the two requires further evaluation with vessel wall imaging or digital subtraction angiography. Vessel wall imaging can resolve this uncertainty. In this example, pre- and post-contrast vessel wall images demonstrate homogeneous high T1 signal intensity within the aneurysm sac, consistent with organized thrombus rather than residual flow. The 6-month angiogram confirms complete aneurysm exclusion. Thus, adding vessel wall imaging to the protocol can significantly improve diagnostic confidence in assessing aneurysm status following stent treatment. A typical intracranial vessel wall MRI protocol includes the following sequences: axial T2 space for structural assessment, 3-dimensional TOF-MRA for luminal imaging, axial precontrast 3D-T1 black blood imaging, post-contrast acquisitions, including axial and coronal 3D-T1 black blood. Total scan time averages about 25 to 35 minutes, with each sequence contributing between 3 and 15 minutes depending on contrast use. This comprehensive approach allows simultaneous evaluation of luminal stenosis and vessel wall pathology. Vessel wall MRI also provides valuable insights into untreated aneurysms. In this case, a 5 mm left MCA bifurcation aneurysm demonstrates circumferential enhancement of the aneurysm wall following contrast. This finding has been proposed as a biomarker of aneurysm instability and may reflect subclinical sentinel hemorrhage. In fact, this aneurysm was subsequently treated with endovascular coiling based on its imaging profile and associated risk. Here, vessel wall imaging clarifies the cause of acute stroke. A patient with an acute Pontini infarct on diffusion weighted imaging is found to have high-grade basilar artery narrowing. Vessel wall MRI reveals eccentric, non-circumferential wall enhancement at the stenosis site. This pattern is typical of active atherosclerotic disease, in contrast to the circumferential enhancement seen with vasculitis. Thus, vessel wall imaging increases diagnostic confidence and directly informs therapeutic decisions in patients with intracranial stenosis. In some cases, vessel wall MRI helps differentiate vasculitis from atherosclerosis. This patient has moderate narrowing of the left middle cerebral artery, along with a recent subacute infarct in its vascular territory. Black blood imaging demonstrates marked circumferential wall enhancement at the site of stenosis. Unlike eccentric enhancement, which suggests atherosclerosis, circumferential enhancement is characteristic of active vasculitis. Additional T2 space imaging further supports the diagnosis, showing low signal intensity at the enhancement site, a finding consistent with vessel wall inflammation. To summarize the role of head magnetic resonance angiography, non-contrast TOF imaging remains the first-line sequence and is diagnostic in most cases. It is particularly effective as a screening tool for suspected dural arteriovenous fistulas. However, it is susceptible to artifacts in regions of slow or turbulent flow. In these situations, contrast-enhanced MRA should be considered, especially for treated aneurysms or known high-grade stenosis. Vessel wall imaging adds an additional layer of diagnostic confidence, particularly in cases of vasculitis, active atherosclerotic plaques, or aneurysm risk stratification. Spinal MRA is performed far less commonly than head or neck MRA, but when done properly, it can be invaluable. The main indication is the preoperative assessment of spinal vascular malformations, such as dural arteriovenous fistulas. Because these studies are relatively rare, technologists often have limited experience with them. Whenever possible, spinal MRA should be scheduled during daytime hours when an experienced radiologist is available to provide guidance and troubleshooting. In this example, sagittal T2 MRI demonstrates abnormal intradural flow voids consistent with a dural AV fistula. Planning a spinal MRA is the logical next step in preoperative workup. A suggested spinal MRA protocol includes 3 plane localizer images, dynamic time resolved contrast enhanced MRA, tailored to the level of interest. For cervical dural AVFs, imaging is acquired in the coronal plane, covering from the skull base to the aortic arch. For thoracolumbar dural AVFs, imaging is obtained in the sagittal plane, covering from approximately T4 to S1. Finally, 3-dimensional rotational reformations are performed to delineate vascular anatomy. Acquisition time for the C sequence is about 30 seconds, followed by several minutes of post-processing by the technologist. This case illustrates the classic appearance of a spinal dural AV fistula. On sagittal T2 MRI, multiple intradural flow voids are seen, suggestive of abnormal venous engorgement. Time-resolved MRA confirms a type 1 dural AVF, in which the fistulous connection lies within the spinal foramen. Abnormally dilated, arterialized posterior medullary veins are clearly visualized, along with potential arterial feeders arising from radicular branches at the T7 and T9 foramina. These details are critical for surgical and endovascular planning, as they allow the interventionalist to target the precise level for treatment. Intraoperative findings confirm the value of preoperative spinal MRA. In this patient, digital subtraction angiography identified a radicular artery at the T7 foramen as the feeding vessel. Embolization was then performed, and subsequent imaging demonstrated complete resolution of abnormal medullary venous opacification. Because spinal angiography is technically demanding, the ability of MRA to suggest the precise level of a feeding radicular artery is extremely valuable. It shortens angiography time and greatly assists the interventionalist in targeting therapy. Quantitative magnetic resonance angiography, or qMRA, is not yet part of routine neurovascular protocols in most institutions, but it is an active area of research. Using a phase contrast technique with bipolar gradients, qMRA allows direct measurement of blood flow velocity and volume, expressed in milliliters per minute. This approach has already been widely applied in cardiac imaging. In the neurovascular field, early studies suggest that qMRA may help predict which stenoses are hemodynamically significant and may even anticipate the risk of hyperperfusion syndrome after carotid intervention. As technology advances, quantitative flow assessment could become a routine adjunct to anatomic MRA. Let us consider a real-world clinical example. A 68-year-old man presented with intermittent right-sided weakness and transient ischemic symptoms over the course of a month. His brain MRI was essentially normal, showing no acute infarction and only minimal white matter disease. Carotid ultrasound demonstrated a left-sided plaque with less than 50% stenosis. In this scenario, contrast-enhanced MRA revealed additional information not apparent on ultrasound, prompting further discussion between the neurologist and the radiologist regarding management. This case underscores how MRA provides incremental diagnostic value beyond conventional imaging. To conclude, contrast is not required for most head MRA examinations, as TOF sequences usually suffice. Contrast is recommended for most neck MRA studies, when feasible, and for evaluating treated intracranial aneurysms. Why include MPRAGE in neck imaging? Because it detects vulnerable carotid plaques and helps identify dissections. Why add vessel wall imaging in head MRA? Because it helps characterize stenosis, distinguish vasculitis from atherosclerosis, and stratify aneurysm risk. Together, these protocol refinements enhance both diagnostic precision and clinical relevance. Neurovascular magnetic resonance angiography has become a cornerstone in the evaluation of cerebrovascular disease. With continued advances in sequence design, coil technology, and adjunct techniques such as vessel wall imaging and qMRA, its diagnostic capability continues to expand. Ultimately, the goal of MRA is not only to visualize anatomy, but to provide actionable information that guides clinical decision-making, improves patient outcomes, and advances our understanding of vascular disease. For further educational resources, please visit the Society for Magnetic Resonance Angiography at society4mra.org.